Thank you very much for being here. I do have a conflict of interest because I'm one of the associate editors in ICM, and maybe you didn't think that ICM is the journal to publish your ethical conundrum, but I will show you that it is. And I'm going to show you too many papers, so buckle up and enjoy the ride. I'm going to talk to you what we've published in the last year pertaining to family, to age and frailty, to children, something about discrimination and conflict, and I will finish with well-being. So here we go. So this first paper, it's a letter. It is a population-based study. It is retrospective, but it looked at about 27,000 consecutive patient admissions in Canada. And it basically looked at family visiting and how much of it is documented, and they did some associations and they came across some very interesting results. So basically look at the associations there. So more of the patients that were visited were younger, they were female, and most of the visiting happened when the patients were ventilated and when they had delirium. And they looked at some outcomes, and this again is association. They saw that the patients that were visited, and that is also either virtual visiting or in-person visiting, they had a higher length of stay, a higher stay in hospital. They died more, and they died more in ICU, and they died more in hospital. And then, as Gert said, this is what happens. Something gets published, and then if it's interesting, there's an editorial. This editorial came out, and clearly, of course, the paper didn't mean to suggest that if you have a visitor, you'll die more. Clearly not. But it did show something else more interesting. So visiting was more common at day 1 than in day 7. So the more the patient stays in ITU, the less they are visited. The sicker patients and the ones that had delirium were visited more, and then again that makes sense because in the beginning of your ICU stay you're sicker and you have delirium, and then about 92%, so 1 in 10 of the patients in ICU had no documented family visiting. So again, if we were to draw some conclusions out of it, first of all, what about the timing of visiting? And maybe we should coach families to visit differently, so the quality of visiting maybe should be different. And then what about this 1 in 10 families that don't have anyone to visit, and could we use this as a marker about what happens after ICU? Is this a marker of isolation? Could we use this as something more? So this is from Nancy Candice-Barnes and Elia Zoulay, the French group, and this is the paper of the year for ethics in ICU. It's a big study, it's a multi-center study, and what they did is they looked at patients at higher risk of dying in ICU that were conscious, and they tried to discern what concerns they might have around their end of life, basically. And this is what they found. They found 7 domains, and 7 domains, the most common one was their concerns around the quality of care and symptom management. Then the other one was being oneself, concerns around spirituality, religion, and existential preoccupations, death and dying, concerns about the loved one, and the others were too small, so after-death preoccupations, and so on and so forth. And they found the many questions, and they put them into clusters, and they ended up with these 15 questions. And questions / concerns about, again, patient at high risk of dying, conscious in ICU. So will I suffer? Will my loved one suffer because of my illness? Can I trust the care? And are you competent? And what about my symptoms? Some people said, I feel this is okay, I had a good life. Other people were concerned about what support spiritually and religiously they were going to have. Concerns around isolation, concerns about how dependent they might be and how incompetent they might be. Some concerns around dignity. This is quite unique because it does what it says in the title. It gives voice to patients in ICU. There are some concerns that the authors highlighted them. It comes from France, it comes from only a few institutions, and a concern that I'm sure some of you might raise is I don't know how many patients you have at risk, high risk of death, and they defined high risk of death by the SAPS score, but I don't know how many patients you have at high risk of death in your ICU that they are actually conscious and able to have a conversation. Nonetheless, it does provide valuable information, I think, on this area. I also like this very much. The title confused me initially. It talked about argumentation in end-of-life conversations. It is a Dutch study, and it is a qualitative study. Surprise, surprise, it's a big thing for ICM. It looked at about 100 recorded conversations with doctors and families in neonatal, pediatric, and adult ICU. And they tried to see what arguments, what statements, how do we try to approach decisions around end of life? So they focused on conversations around end of life, and mainly what happens if we disagree and how we proceed with that. So this is what they found. They found 10 main, they call them arguments, statements, or whatever. These are the most common ones. And you will recognize, I think, yourselves into that. When you approach the family and say, look, we have to stop, it's not going to get any better than this. When you use proportionality, when you say, well, what we do might help now, but they will never survive ICU. When you talk about quality of life, and these quotes are either from the family or the doctor, so sometimes when the family agrees to limit treatment, then they say, yes, they look more at ease now, and so on and so forth. They found that the fourth one, uncertainty, was used more by younger clinicians, which now seem to understand that there's uncertainty and maybe embrace uncertainty. But what was really interesting, I found, is that the way we communicate is far, beyond, it's not optimal. So what they found is, first of all, the argument and the statement about we're now approaching end of life and we should do this came from a physician, and of course, that's fine, we hold the information. But then they found that the counter-argument, the response from the family to that we need to stop now statement never came as an exact response. So we would say something like, we need to stop now. The family would probably say something along the lines of, he's a fighter or whatever, and they would come back to the statement of a response to we should stop further down the conversation. And when they did, the physician never really picked it up. And they found that what really happened is we tend to talk at each other, but not really in overlapping statements, to each other and with each other. And something else that was more interesting is even statements like, maybe it should stop, my loved one is suffering, were not really explored. So these kind of statements were just left to hang. So when we came out with a statement about stopping or limiting treatment, if they agreed with us, that's one pathway, they agreed quite quickly and the treatment was stopped. But if they disagreed, then the majority, more than 95% of the time, the end result of that was just to continue treatment. So it wasn't really productive conversations. So if I finish this section and to take some take-home messages is family visiting is of course very important, but we now need to move on from just, oh yes, the family is visiting, to really clearly document the quality of the visiting, the nature, the timing, when is the optimal frequency of their visits, and actually think about what about these patients that don't have family, is this a marker for anything else? So I'm going to move on now to frailty and aging, and this is a byproduct of the VIP study, the VIP2, so the very old elderly intensive care patients. We had about 2,000 patients, observational prospective study, including patients that were more than 80 years old, so octogenarians or older, admitted to 22 countries in ICU. So this is very good because I think that answers a lot of questions that we might have about how much and when and if we should admit old patients in our ICU. So, so clearly they found 7 phenotypes, and it's really good that we're talking about phenotypes now, and it's nothing to do with age, but it has to do with frailty. Look at the clinical frailty score at the end. So basically the non-geriatrics, they're old, but they're not frail. but the geriatrics, they're both old and they're frail and they come into ICU with comorbidities. And if that happens, then clearly they die more. You see that the G phenotype basically has a 50% ICU mortality, a 60% hospital mortality. And then this editorial basically said, don't think only about frailty, think about frailty and put it in your diagnostic algorithm, and this as a take-home message as well. So these patients just don't think only about age, think about their comorbidities, measure their comorbidities, measure their frailty, and then put this in your decision-making. The other spectrum is children, and we all struggle a little bit when we have children here. So this was 2 academic centers, 100 surveyed families. And is this a problem? Well, yes, it is, because they found that about 40% of their patients had children, patients in ICU also had children, and about 87% of them had difficulties explaining to the child what was going on. And if about 55% of the children wanted to come, only 23% did. So that is a problem. I recommend this thoroughly. This is 10 recommendations about child-friendly visiting policies in ICU, which basically says, make a decision. Is it appropriate? Is it not? Prepare, prepare, prepare. Make sure that when the child is there, the appropriate people are there, manage the visit, give appropriate information, and then never, ever forget to just follow up that visit, especially if it's about a death of the patient. A little bit about conflicts. There are 2 articles that were published. This one is from the Medicine Sans Frontières that basically reminds us in conflict zones, it's not only about conflicts. So what they found here is that in conflict zones, maternal emergencies, trauma, sepsis, and children are the ones that suffer more. And this came from the Ukraine. That I know they found a way to not just look at the positives, the negatives, but also the positives when you practice medicine in a conflict zone. I can't not talk about sex and gender differences in medicine. Basically, we are different, and we have a ponytail, and guys don't have a ponytail. But apart from that, we have pathophysiological differences, pharmacodynamic, pharmacokinetic, and we respond to disease very, very differently. So when studies are designed, please provide sex disaggregated data, think about hormonal status, and think about modifiers, so gender modification. I'm going to finish with some studies around well-being. This is really interesting by Lauren Papazian and co-authors about a systematic review about high burnout in nurses and physicians. They included studies that only used the Maslach burnout inventory. They did an amazing work, 20,000 co-workers, COVID versus non-COVID. What I want you to, and the 3 domains of burnout, I hope we're all aware of that. What I want to point out about this study is that it is a mess. So burnout and the way we measure burnout is a mess. So we either use all 3 of the subcategories and we add them and there's a mean. We use 2 of them plus or minus the other one. And it always is very impressive to me that we have found a way to measure and have criteria for ARDS that is completely made up disease, but we still cannot do this for something so important. If we can't really measure it, we won't be able to really find a cure for it. This is about doctors and nurses, and there wasn't such big difference between them apart from the emotional exhaustion bit. Nothing else, not everything is lost, because this letter showed that there is a very simple, for example, therapeutic intervention. So it was a training program. It was only about 2 hours, I think, on the risk of burnout and therapeutic communication. And it did find that maybe there wasn't a statistically significant difference for all 3 subgroups, but it did statistically decrease depersonalization. Some snippets of how impressive it could be and some therapeutic about music in ICU, about making your ICU look more than a home, some inside stories. And I'm going to finish here by telling you that burnout, we need to be able to measure it. It is a massive problem, and this is WHO predicting that in 2030 there will be a shortage of 18 million healthcare professionals. You just don't wake up in one day and you are burned out. It's insidious, and you need to be able to identify it, measure it in order to prevent it. And with that, I thank you. Oof.
Thank you very much. Questions?
Breathless.
So you referred to that in the first study, very complex, asking about the questions that the patients and fears has. It was a limitation that it is from France only. But it was very, very well done. What can you speculate what would have added other countries? Because I think it was a very nice list and very elaborated.
Yes, so I think that's a very good question. So first of all, it's not that we're all human. It's not that the French people will be different than other people. The authors did mention that as well. So two things I have to answer. So first of all, it is amazing that if physicians were to ask themselves, what are my concerns if I am to die, they would come up more or less with these 15 questions. And I do think that the authors also wondered whether that was some bias and some self-fulfilling prophecy bias, that we came up with concerns that basically are our concerns. And the other thing is that, for example, depends on your bed capacity. So that I don't think could have worked in the UK. You couldn't ask maybe people from the UK mainly because we don't have the admission capacity to have patients that are conscious and yet so sick in our ICUs. So I think that is the problem.
Thank you very much.
Okay.